And good evening, everyone. My name is Franklin. I'm one of the two co-founders of NorCal SCI, also better known as the Northern California Spinal Cord Injury Foundation. Welcome to tonight's presentation on what you need to know about pressure injuries and flap surgeries, featuring Dr. Kazuko Shem and Dr. Deepak Gupta, both well-known in their fields here at Santa Clara Valley Medical Center, one of the top SCI rehab hospitals in the country. As usual, just a few things that I want to share with you before we get started. Both of our speakers have an exciting and informative presentation that they're going to be sharing with you. So everyone has been muted in order to eliminate any background distractions. And we know that you are going to have a lot of questions to ask of the two presenters. There will be a Q&A session upon the conclusion of their presentation. So I'm going to ask you to use the chat feature in your Zoom screen to feed me any questions that you have all throughout the presentation, and I'll be sure to ask them during the Q&A session. Second thing is, as always, all of our presentations are made possible thanks to the generosity of our donors. So we're grateful to them for supporting informational and educational presentations such as the one that you're about to witness tonight. And finally, in the event that you need to jump off the call, because I know that there are some people on the East Coast and also a couple of them outside of the country, we are recording tonight's presentation, and there will be a recording in your inbox first thing tomorrow morning. And that way you don't have to worry about missing a beat. So with that in mind, let me get started and introduce our speakers. Dr. Shem is the Chief of Physical Medicine and Rehabilitation Clinic at Santa Clara Valley Medical Center, which again, as I mentioned, is one of the top SCI rehab hospitals in the country. She joined the PM&R, basically the abbreviation for Physical Medicine and Rehabilitation Department, in 1998 at the hospital, and her interests are in spinal cord injury medicine, electrodiagnostics, general rehabilitation, and clinical research. She's predominantly involved clinically in seeing patients in the PM&R clinic, basically on an outpatient basis. And in her time at the hospital, she has probably seen a couple of thousand patients at the very least, I would imagine. Dr. Gupta is a surgeon also at the hospital's plastic and reconstructive surgery division and has been practicing there since 2018. He is board certified with the American Board of Plastic Surgery and is currently the assistant director of the Burn Center at the hospital. He's also clinical assistant professor at the Stanford University School of Medicine's Division of Plastic and Reconstructive Surgery. And I'm thrilled to be able to welcome both of these distinguished speakers. Dr. Shem, take it away, please. All right, we'll just wait for Dr. Shem to. Dr. Shem, if you could.
Yep.
There you go. Okay.
Yep.
All yours.
And is it shared or not yet?
Hold on a second. Yeah, it is shared, so you should be able to.
It's shared. Got it. Okay, thank you very much. Thank you, Franklin, and thank you for this invite to again speak at this lecture series. And I believe this is my third time, so I'll take it as a good thing that I got invited again to speak on a different topic. So here we go. And I really want to also give Dr. Gupta enough time at the end. And I don't know why it's not going. Okay, all right. So objectives, I think you already saw on the ad for this talk. So I'm not going to really go over this too much, but hold on a second. But I'll be primarily discussing about pressure sores from conservative management standpoint. As I think Dr. Gupta will agree with me, actually managing pressure sores in people with spinal cord injury, 90% of it is really conservative. Surgery is a relatively minor part of overall pressure sore management in SCI. So we'll be talking about, again, conservative management, like dressing changes and how to avoid pressure sores, and what can we do? What can you do? I think that's the big question here today. All right, so just conflict of interest and disclaimers. I don't have any conflict of interest for this presentation today. I do have 2 current research projects that are federally funded, but not associated with the today's talk. And then also I wanted to really give people a heads up that there will be graphic pictures that will be shown, and especially the next slide, I'm going to have some graphic pictures. So I do want to give people a heads up that there will be some graphic pictures. Okay. All right, so what are these skin lesions? Okay. So as of 2015-ish, medically, technically speaking, they're called pressure injuries. But we've been calling them pressure ulcers, decubitus ulcers, or the cubes, pressure sores, or just simply sores or wounds. But all these are pressure injuries due to spinal cord injury. It could be due to other reasons, but as long as there is a open skin or skin lesions due to pressure, we call them pressure injuries. Okay. So why do these pressure sores happen to begin with? It's ultimately pressure, pressure, pressure. So if we are to all sit still for 50 minutes, and regardless of spinal cord injury, if we don't move at all, after 15 minutes, our skin cells start to get damaged, and unfortunately cells could die because of pressure. And there are other considerations like how deep that or strong that pressure is. And I can show you more reasons why these pressure injuries happen and why they don't heal well. So in people's spinal cord injury, unfortunately, we see about pressure injury, 80% of patients at some time in their life of being injured. And there are multiple predisposing factors. So loss of sensation and movement, and then skin is also not as elastic below the level of injury. There may be muscle atrophy that puts more pressure on the skin. And then also circulation may not be as good as before the spinal cord injury. And other considerations we need to make and risk factors are things like moisture. So sweating, urinary incontinence, stool incontinence, skin infections, poor nutrition is very common, even for people who look overweight or obese. Sometimes the nutrition itself is not that great. And also there's aging. Many of our patients are living a very long time now with spinal cord injury, but with aging, our skin does become more fragile. And unfortunately, some of our patients also like smoke, which is a really not a good thing for the skin. So I'm going to relatively briefly go over the different stages of these pressure injuries. So when you come in and see healthcare providers for skin injuries, we grade them from stage 1 to stage 4. So stage 1 here is this just redness here. It's called non-flangeable erythema or redness. So the skin's actually still intact, but if you push on the red area and then release your finger on that, and then if it remains red, then that's considered stage 1 pressure injury. Okay. This is stage 2, where just the superficial skin is out and it's open, and sometimes these may start with like blisters where the blisters rupture, and then when the blister skin is removed, you might see something like this. So blister actually for spinal cord injury patient can frequently mean that there's pressures that is causing that blister to happen. And then this is the what we call stage 3 pressure injury, where there's full skin, loss of skin. But we don't see anything much more underneath, just loss of the superficial skin, and you still see a little bit of fat here. Okay. And this is stage 4, or the worst stage of the pressure sores. And stage 4 can be really, really variable, but as long as we see muscle, tendon, ligaments, bone, then these wounds are called stage 4. Okay. And then there's also what we call unstageable pressure injury. So unfortunately, sometimes we will see this kind of breast pressure sore first, where the skin is dead or non-viable, and it's blackish. And we can't stage these because we don't know how deep this wound is or how big the wound is. So once this black part is removed, then we can say what stage it is. But usually on a wound like this, it's pretty much given that the patient will have a stage 4 pressure injury. And then there's pressure injury where a medical device can cause a pressure injury, such as bracing tubes, like rectal tubes, oral suctioning tubes, if somebody have it on the mouth, casts, collar, bed rails. So all those medical devices can potentially cause pressure sores. And but we stage them from stage 1 to 4 when we see these. So this is not just for people with spinal cord injury, because people with stroke, cerebral palsy, people who are not very mobile, patients who are hospitalized can get pressure injuries if you're not moving around. So it depends on the size of the pressure injury. It really depends on the positioning. So most patients in the hospital are lying on their back. So we see pressure sores on their heels, tailbones, sometimes shoulders, and sometimes back of the head. When patients are lying on the side, we see them more on the ankles, side of the knees, maybe the hips and shoulders. If you're sitting up, then we start seeing pressure sores on the buttocks, sometimes on the heels, especially if it's rubbing against the wheelchair. Sometimes we may see it on the shoulder blade area if the backrest is rubbing on the skin. Yeah. And for people with spinal cord injury, when you have the pressure injury, where the pressure injury might occur, can change based on where you are along your spinal cord injury. So if you're acutely injured, like in the hospital, there are about 30 to 50% patients who will develop pressure injuries within the first month. And most of the pressure injury will happen at the sacrum or the buttock area, but more like a sacrum, right in the middle here. Okay. And then in the chronic setting, when patients are at home and maybe patients are sitting more, then it's kind of more in the more generalized buttock area. So it could still happen on the sacrum, but a lot of it can happen on what we call ischial bones or these sitting bones. Those are the most common areas. Then we can see them in hips, sometimes on the heels and hips. So when there is a sore, a patient should be evaluated. If you are one of our patients here, we really recommend that you contact us immediately as soon as you get some skin lesions, because sometimes it may not be pressure sore, but a lot of times we can really guide you what to do right away if you notice some skin lesions. And these days, people send me pictures all the time, and rather than coming in, which is really actually preferred, because any pressure really needs to be avoided when you're developing pressure sore. So, people send me pictures, but usually this is what we need to do when we see significant pressure sores. So occupational therapy referral. So we refer patients to occupational therapy for seating eval, pressure map, review weight shift techniques, transfer techniques, looking at shower bench and commode. And then from labs, we look at things like anemia, iron deficiency, panel 7, testosterone level, which often is low in male with spinal cord injury, thyroid, vitamin D, and prealbumin, albumin, looking at nutrition status. So we usually get a full lab test. And then we look at things like smoking, obesity, and then we'll ask you about bowel management, bladder management, and making sure sure we avoid any accidents and incontinences that can soil the wound. And then we also look at psychosocial situation, especially if we have to ask you to stay in bed. That's very difficult to do. We usually frequently ask people to stay in bed 24/7. So that means we have to look at your attendant care availabilities and your mental health. Yeah. So I'm sure most of you have gone through this, but in acute setting, we usually have patients turn every 2 hours, side to side at home. Oftentimes that's not really necessary, but every 2 hours is optimal. We can use heel protectors. I think some of you already have Prefo boots at night to protect the heels. We do a lot of patient and caregiver education, how to do pressure reliefs. So pressure reliefs in the wheelchair really needs to happen actually 1 to 2 minutes every 30 minutes, preferably, and that's very difficult to do. Manual wheelchair users, you will usually have to do a lift or lean forward or lean to the side. People with power wheelchairs can do tilts, recline, but pressure reliefs really need to happen adequately. And then in bed, if you're at home, we really need to avoid this positioning where the head of bed is up about 30 degrees. People feel really comfortable with this position. So we see this in the hospital, we see this at home. For those of you who have a hospital bed, this is really, really bad position because all the pressure goes onto the sacral area and then can cause pressure sore. So we may have to ask you again to limit out of bedtime. I frequently will ask you to be off 24/7, depending on the site of the sore and size of the sore. But the smaller the pressure sore, when it's found, it's faster and easier to treat. And the key again is no pressure. So the faster you get down and then we let it heal, we can avoid prolonged bed rest and we'll manage it afterwards. And again, here showing how maybe you can do a transfer, look at your transfer techniques. We have commode chairs and shower bench. We want you to look at them because these get old and plastic can fray off and that can damage your skin. So then we need to replace those equipment. And then we can re-educate you about bowel program and refer you to nutrition counseling. My room is telling me I'm not moving enough. It just went dark. Anyway, so here are types of wheelchairs that we really don't want you to use at all. Okay, so please do not use these type of chairs or wheelchairs if you're a spinal cord injury patient. And these are cushions. So this is a J cushion, Rojo cushion. This is the Stimulate honeycomb and the foam. Foam for sure is a big no-no. Most patients with spinal cord injury will end up getting a deep J or deep Rojo. Okay. And this is a pressure map that we can do with our occupational therapy. So here, these are legs. This is your buttocks. We do not want to see any red. And then we can also do pressure map of different cushions to make sure, is it J cushion that's a better fit for you or Rojo cushion that's better fit for you. And then for sure, please do not do any donut cushion because your tissue, your buttock is going to go into that hole and then actually can strangulate and cause us more pressure. So please do not do donuts or anything like that. Okay. Beds. So many of you may have hospital beds and some of you may not have hospital bed, but there are things like egg crate foam that you can put on top of your mattress. P500 that you see here is a only for inpatient. So some of you who have gone through our rehab here, P500 is our standard bed, but this is only available in the hospital setting. But the low air loss pressure mattress, you can get it. Usually insurance will cover it only if you have a pressure sore. So that's the hard part. And insurance pretty much dictates the brand, the model, even the vendor. So getting a hospital bed with a low air loss mattress is frequently challenging. And I'm just showing you, these are the beds called air fluidized bed. Some of you may have seen this in the hospital, but there's sand, floating sand in there. And then if you have pressure sore in the hospital or post flap, you might be using these type of beds. And this is just a long list of wound care. So I'm going to start talking about wound care and dressing changes. I do want to just mention that hyperbaric oxygen, if you live locally here, they are available at O'Connor and St. Louis Regional, although for patients who have given a try, my patients have not really benefited from that, but just want to mention the hyperbaric oxygen is available. So really, there are really different types of dressing changes. So xanthal or collagenase can chemically debride wounds that are not looking well, like the black wound that I showed before. This will help to clean up. Sometimes you need what we call surgical debridement, which someone like Dr. Gupta or some wound nurses may need to do. Sometimes you have to go to OR. Sometimes you can get it done in the wound clinic. And then there are occlusive, what we call occlusive dressing that will close the wound, and by that the wound can become otolytic or get cleaned up by itself. And then sometimes we can use a transparent membranes to just cover a superficial wound that's not draining a lot, and you can see through the dressing changes. And many of you are probably very familiar with the these two right ones, the Alleven and the Meplix. These are very good foam dressing coverage that is not too sticky, and they're cushy. Many of our patients do use these dressing changes, usually covering on top of the other dressings. And then sometimes we use this thing called hydrophilic blue bacteriostatic foam dressing. This is very absorptive and not adhesive, so it can absorb drainages and protect your skin. Alginate is very commonly used, especially if you have lots of drainage, because it's made of seaweed, so it really absorbs the fluid that comes out of the wound, and the wound leaks a lot, drainage. So you do need to drink adequately because a lot of the water and the nutrition unfortunately will leak out of the wound. Okay. And then here are some other ones that we frequently use. So mesol is used when the wound is what we call hypergranulated or growing too much. Then we might use that. We also can use Medihoney, which is a honey product that acidifies the wound and minimizes the bacterial infection. Iodosorb uses iodine, similar concept. It's a kind of bacteriostatic. And then Biostep is another product. It's a matrix collagen product that we might use. And then the VAC, what we call VAC, wound care sponges. This black sponge goes into the wound bed, and then it will be covered, and then it vacuums the drainage. So it's good for relatively large wounds, and then for those that have lots of drainage. But we can't use it if there's a lot of active bone infection. The cautionary tales on these is that there is this a tube that comes out of this. So if your wound is on the buttock, I usually recommend you don't sit on it. The pressure is going to be worse. You might get a pressure sore from like the tubing. And the other caution about this is that when you're changing the wound, to make sure that this black sponge comes out all in one, and no pieces of sponges are left, because we have heard of complications where the sponge got left and then the wound didn't heal because the sponge was unfortunately left over. And these are changed every 2 to 3 days. Some family members can do this, but most of the time, either home health or wound clinic will be managing the VAC. And then here is the ultrasound. So we used to use this when we used to have our physical therapy wound clinic here at the Valley. I'm not sure if they're using it at O'Connor or St. Louis, but it's a low frequency ultrasound that cleans the wound and promotes healing by the ultrasound stimulation. And then just want to touch base on the osteomyelitis or bone infection due to pressure ulcers. So it's from the pressure sore because it's kind of close to the wound, the bones. The bone can sometimes get infected. So we know it's about 5% of people with spinal cord injury can get the osteomyelitis or bone infection. Overall, these bone infections are most common in the sitting bone, the ischium, the hips, maybe sacrum, and probably Dr. Gupta can probably mention a little bit more about what to do with these when you have bone infection. But these are more common when you have larger wounds, wounds that's been there for a very long time. Okay. And some of the predisposing factors for the bone infections are what we call heterotopic ossification, or HO, which is extra bone that can build around like hip joints, vascular problem or blood vessel problems. Maybe there's a presence of foreign objects or fusions. This person happens to have, I think there's a bullet in his and blood fragments in his body, and history of bone fractures, and comorbidities like diabetes. Okay. And how do we diagnose bone infection or osteomyelitis? So we really need biopsy for this. And we can do MRI, but usually with a patient with a deep, large wound, MRI is going to be abnormal. But that doesn't necessarily mean that you have an active infection. We don't usually do culture of the wound because the wound is exposed. So the bacteria is all over our skin, whether it's open or not. But especially in for wound, there's going to be lots of bacteria that's you're kind of colonized with. So it doesn't really help to culture the wound. And then also we don't do bone scan because bone scan usually will be positive because there's a lot of irritation or inflammation due to the pressure ulcer nearby. So the ideal gold standard for diagnosing the bone infection is biopsy. And then Dr. Gupta and I will sometimes order MRI to see if what's going on in the hip. I think that this is a hip joint that kind of got unfortunately destroyed by the infection. And then some patients will get surgery. If you have bone infections, for sure, you need to get antibiotics. For some severe cases, unfortunately, we may need to consider amputation or removing parts of the hip joint to avoid further infection. And before I pass on to Dr. Gupta here, just want to mention that the Paralyzed Veterans America, PVA, has very good clinical practice guidelines on multiple topics. One of them is the pressure ulcers. So they have both the clinical practice guidelines and consumer guidelines. These are free online. So I really like to strongly recommend you take a look. And if you also have providers who may not know, come across providers who may not know much about things about spinal cord injury, and there are topics on depression, upper extremity preservation, DBT, clot prevention, nutrition. There's a lot of consortium guidelines that are out there, autonomic dysreflexia. So I'd like you to take a look at the PVA website and then get access to that. So Dr. Gupta, we'll let you talk about flap surgery.
All right. Thanks, Dr. Shem. I'm now going to turn the co-hosting privileges to Dr. Gupta so he could share his screen. Thank you, Dr. Shem.
You're welcome.
Thank you, Kazuko. And thank you, Franklin, for inviting me. I'm really excited to be here. And I hope I can continue along with Dr. Shem and making this an annual tradition for us. It's also, I'm unable to share my screen, Franklin.
Okay, just one more second.
No problem. Since I'm logged on twice, I just wanted to, it's the one with the black screen right now.
Okay, you should be good.
Yep. Okay, can everyone see that?
Yes.
Thank you. I just want to remind everyone, please start entering your questions in the chat box. It is still empty, and Dr. Shem and I can answer some of those when we're done. I just wanted to say that it's been such a pleasure working with Dr. Shem, and I totally agree with everything she said. It's really challenging. I really rely on her to handle a lot of the pressure sore management, and I'm happy to, of course, do my part. And so these slides are slides I use mostly to teach our residents, and these are our plastic surgeons who are in training, and I'm on the faculty at Stanford University. I've removed a lot of the redundant slides, so I'll talk about the surgery aspect. I also wanted to disclose no conflicts of interest, and my slides also contain some graphic images. So I just wanted to underscore again that, you know, what my consideration begins with the fact that I have to realize that these wounds are multifactorial, and you know, it's not a perfect system when we see patients and analyze all this. We do our best, but it is very complicated. And I think for me, what has worked very well, and especially working with Dr. Shem, is really getting to know you. And I think that allows us the best chance at kind of addressing all these factors. But when I do see you, these are the things I really focus on: is what's the wound history, how did it start, how long has it been there, what prior treatments and procedures have been tried, and what kind of wound care has been performed, and whether or not the wound is getting worse or getting better. So what's the trajectory of the wound? And sometimes I can't gather all that information in one visit. So sometimes it is over the course of 2 or 3 visits. You know, we're always taking measurements as well as, you know, making sure we characterize the wound. And like Dr. Shem mentioned, making sure we take note of what's exposed. Is it bone? And are you at risk for osteomyelitis? So osteomyelitis is something I did want to talk about, and thank you, Dr. Shem, for giving me the chance. So this is a big problem with this disease entity. So unrecognized osteomyelitis is a major source of morbidity and cost. These infections are very, very tough. It's the major reason why a wound might not heal. It is a major reason why a wound might come back after surgery. It's difficult to diagnose, and they're difficult to clear. The reason it's difficult is because we as human beings clear infections with our immune system. Our immune system starts in our bone marrow, travels through our bloodstream, and mostly takes the form of white blood cells. Bone, when you have an infection in a bone, it's a problem because bones in general don't have a lot of blood. And so if your immune system is in your bloodstream and the blood is not getting into your bones, how does that infection get cleared? Well, you could physically remove it, and that's a surgical procedure. We can physically remove infected bone. But yeah, it's really hard to clear infections kind of on your own once they're in the bone. So the diagnosis is important. We use bone scans, CT MRIs, and also needle bone biopsy. That's by far the most important thing that Dr. Shem also mentioned. When I meet a patient and considering pressure sore surgery, these are some of the things I think about in selecting who should have surgery and who would benefit from it. Because if you're not going to benefit from surgery and I do the surgery, then I've only harmed you. So a patient should be optimized. Again, shouldn't have obvious risk factors such as poor nutrition, you know, poor healing, poor wound care, poor support, or maybe poor coping. And you know, then a surgery is not the right option. Overall, again, all these factors are part of our risk assessment. There's a number of different scales. One of those is the Braden scale. And then as part of that, there are 6 subscales. So kind of what sensation is in the area, what's the moisture like, what kind of activity is the patient participating in, what's the mobility, the friction shear, and nutrition. Surgical treatment, this is kind of the basic steps. Excuse me. Step 1 is excision of the ulcer, surrounding scar, underlying bursa, and calcifications. Step 2, radical remove underlying bone and if diseased. These first 2 steps are by far the most important steps. I spend most of the time in the surgery on step 1 and 2 here. Step 1 and 2 are just so important because these wounds, again, are frequently infected. And I'm not talking about the pussed out, angry, hot red, smelly wounds. And these can be very, very low level, chronic, indolent, infected wounds. And they can look like just normal non-infected wounds. That's what makes it hard, is that just looking at it with the naked eye is not a good way to assess these wounds. And the other thing is that a lot of these wounds have very dense scar tissue, and scar also is not normal skin. Scar is scar, and scar has poor blood flow and doesn't heal very well. So we take a lot of time to make sure we're excising everything that is pathologic, and that really gives us the best chance of achieving a healed wound. Once we've completed steps 1 and 2, the rest of the surgery is to patch it all up. So we have to pad the bone stumps, fill the space between the outside world, the level of the skin, all the way down to the bone. We can use, we resurface with large regional pedicle flaps. Flaps is a term I'm going to use here. It's basically a piece of tissue that can be moved into the area where you need it. And that comes from somewhere else on the body. That other site is called the donor site, which I have here in step 5. Sometimes the donor site can just be stitched back together. And sometimes I have to patch the donor site, so rob Peter to pay Paul. You can imagine a similar example would be if you have a little mole on your skin, you can usually just cut it out and put some stitches in. If you have a little bigger mole, you can still maybe cut it out and put some stitches in. But eventually at some point, you might have a hole so big that you can't just stitch it back together. You have to patch the hole. And so that is something that we have to kind of plan ahead for when we are thinking about these surgeries. This is an example of just an debridement. So chronic sores have this very dense scar tissue, very dense lining. It's basically a well-defined bursa. I use a dye called methylene blue to paint the surface. That helps me know that I've removed all of it, because once I start cutting this out, if I see any blue left, I know that there's still some more scar tissue and bursa left. And so this is one technique we use to make sure that we've actually cleared the wound of any diseased tissue. So after the debridement, what I had here at the bottom was so low threshold for debriding bone. I don't have any pictures of bone debridement, but I have some photos later, which will be helpful. After the debridement, again, we think about what kind of reconstruction we're going to do. That is to patch up the hole. These are some of the terms that you'll see that I would discuss with you during consultation. These are also some of the terms that are listed on some of the paperwork, like the consent form. So we do skin flaps, muscle flaps, myocutaneous. So myo means muscle, cutaneous means skin. So a combination of muscle and skin. Fascicutaneous is fascia is the layer of tissue above the muscle. So is it a fascia and a skin flap combined? And then tissue expansion is something that's a little bit more rare, and it's not something we'll always talk about except in very special circumstances. Again, the choice of kind of how we do the reconstruction depends on multiple factors. Aware of the time, I'm going to try to keep moving here. Muscle flaps are good because they're bulky and they can fill larger wound cavities. They have very good blood supply. As far as a blood supply per gram of tissue, the ratio is very, very high. Muscle is also very, very sensitive to pressure. And so muscle has a very high metabolic demand. That means it tolerates oxygen loss poorly, whereas skin has very low metabolic demands that tolerates pressure better. The nice thing about muscle is that it's very resistant to infection because there's so much blood flow. Again, the immune system goes through the bloodstream. And so if there's more blood flow, it's better against infections. The problem is that muscle is not great at withstanding pressure. Fascicutaneous flaps are in contrast to muscle flaps. Again, the pros, they have adequate blood supply, not especially robust, but they are more durable. So they're good for withstanding pressure. And again, they more closely reconstruct the anatomic arrangement over bony prominences. We have skin and fat over most of our bony prominences and not muscle. So this is one of the examples that Dr. Shem already mentioned. Ischial defects are very, very common. These are some of the sitting bones marked by the gray areas here. And there are really a number of options for reconstruction that we can use. We ultimately decide based on our consultation. So what does the patient need and what has the patient had before? And also what does the patient need in the future? Is this wound going to come back? Is the patient at low risk for a recurrence, medium risk, or high risk? Let's say a patient hasn't had a pressure sore for 20 years and all of a sudden gets one. Why? Maybe it was a very special event, went to a wedding, sat in a van, sat on a plane. And that can be avoided because that doesn't happen every day to someone. So that person might be at a lower risk for recurrence. Here's an actual patient example. So we have here a right-sided wound. This is excision of the wound. I've painted it blue with my dye. I have then marked my reconstruction. I've made my incisions, and below the skin, you see some fat and muscle. I've moved it up underneath the buttock where I need it. And again, this started out as a triangle, and now it looks like a Y. So this is called a V to Y. It started out as a V, and now it's a Y, and this is my donor site. So this area is basically allowing tissue to be moved up into the defect where I need it. This is another example. So this is an ischial wound again on one of the sitting bones on the right side. I've excised the wound. We've taken our time here. This is a much bigger hole than what we started with, and that's very common because what you see on the surface doesn't always end up being the reconstruction. That's really the tip of the iceberg. This is part of the gluteal flap. So this is some muscle and fascia and skin from the gluteal area. We've moved it down into the area where we need it, and then we've stitched it shut. You can see the stapling and the stitching is much, much larger than our initial wound. It's because our donor site, the site that donates tissue, has to be kind of adjacent to our defect. And really, skin is only so stretchy. You can't stretch this much skin into a foot-long piece of flap that you need. So you really have to recruit a lot of tissue and spread that stretch over a larger distance. Sacral defects are also very common. These are kind of very similar drawings to what I just showed you. So sacral defects are in the midline, and there are a number of reconstructive options available to us. This is an actual patient example with the sacral wound. I've excised the wound here. It's much larger, the defect. This is my actual reconstructive challenge here. I've marked out my flap. I've gone ahead and made my incision. I look at some fat in the muscle underneath the surface. I've moved it over, stitched it back together, as well as closed my donor site primarily without a graft. And here's another example. I have a sacral defect. I've excised the wound. It's much bigger. And then I've moved my flap over. I've actually made a much longer line here in case I need it. And in this case, I didn't need any additional tissue. And you can see here a few weeks later, it healed up really well. It's really starting to fade very quickly. This is trochanteric. This is on the side of the hip, these can happen due to pressure from a device on the side or laying on the side. Very, very small looking wound here. When I initially saw the patient, this is a very complicated looking wound once I actually looked under the surface. So this all had to be excised. It's painted blue. I made sure I got all the diseased tissue out. Look how big this flap is. The defects are just so much larger under the surface. I needed a very, very big flap to do this. This came from the back of the thigh here, as you can see, and then I moved it over and, the front of the thigh in this case, and I moved it over to close it all up. It's a little bit bulging out. A lot of this does smooth out over time, but sometimes it's not perfect. But we are able to achieve a healed wound that way. Here's another example of a trochanteric defect. I've excised the wound, very big hole all the way down to the bone. I've cleared off the bone, and then I've done a V to Y again. So you can see my incision here is actually V-shaped to begin with, and then when I stitch it shut, it's Y-shaped. So this Y, the vertical limb of the Y here becomes our donor site. All that tissue that was previously in the V has been moved up into the defect where I needed it. And a few weeks later, you can see here, the skin's looking really nice. Some scabbing along the incision, but it healed up just great. Girdle stone procedure is more complicated. This is common when an infection can become more extensive and extends to the hip joint. I usually require the assistance of our orthopedic surgery colleagues for procedures like this. When you're removing basically the femoral head and neck in a girdle stone procedure, it leaves a very big hole down in the hip. And then my job as a plastic surgeon is to use one of the quadricep muscles, the vastus lateralis, as you can see here, to fill in that hole. So I move that muscle up. Muscle, again, has a lot of blood flow, very, very good at healing, very good at resisting infection. This is a case here where we had a wound on the lateral, on the side of the hip, basically, went and removed the diseased bone. And then here's the muscle you can see coming down here, kind of moved into the defect where we needed it, and this healed up fine. After the surgery, there are some things that we keep in mind. We can't forget why this wound came up in the first place. You know, what did we do to prepare you for the surgery? And we have to continue that. A big part of the postoperative protocol is immobilization. So it's really avoiding pressure on the area for 2 or 3 months. These areas, again, have a lot of scar tissue, a lot of disease, abnormal tissue, and the blood flow is not normal. Blood flow is our lifeline. That's what allows us to heal very well. All the good things are in the blood, like oxygen, vitamins, minerals, and nutrients. Those are all the things our bodies need to heal. And so we can't put pressure on these areas, because as soon as you put pressure on it, the blood flow goes away. The best way to demonstrate that is take your hand, it's pink, you put pressure on it, it turns white, the blood flow's gone, then it turns pink again when you relieve the pressure. So the same thing is happening in the muscles, on the buttocks, in all these areas. We have to avoid pressure until the wounds heal and can become strong enough to withstand pressure. Once we think the healing has been adequate, it can take 2 or 3 months, we start to reintroduce therapy. And then again, part of that is what Dr. Shem discusses, making sure we reevaluate wheelchair cushions and beds and other devices. Dr. Shem and I are always thinking about recurrence. The studies worldwide are highly variable. There are 0 studies where they report 0 recurrence. There are some studies that report 6, but most are around 50%. Some do report 100%. It's all over. A lot of these wounds come up because of our activities of daily life, sitting in a chair, getting in a car, getting on a plane. And we can't stop living our lives, and we can't stop the activities of daily life, because then quality of life goes down. And we do all this to maintain quality of life. And so there is a high recurrence, because these are just intimately related to activities of daily life. But again, because the recurrence can be high, this underscores the importance to make sure we're doing everything we can before the surgery to prepare ourselves for what's to come after the surgery. If you do have a recurrence, we think about why. Was the infection not cleared in the bone? Did we not do the antibiotics right? Was it another airplane ride, another car ride? And or was it a poor bed, a poor wheelchair? And so we have to start all over, look at all the factors. Surgical options, what are they? Sometimes I can use the same flap if it's just a small area where the flap has basically had pressure and died. Sometimes if it's a large area, I have to use a new flap. And an example would be if I use the thigh one time, I might be able to use the buttock or the gluteal flap the next time. Takeaways for me as a surgeon, I need to get to know you. I think that's the best way to achieve the result that everyone wants. I'm so grateful for my partnership with Dr. Shem, and also our ID, I wrote here, ID infectious disease colleagues. They're really specialists in infections, and it's a multidisciplinary approach. And I think that's the strength of our group. Hopefully we're setting everyone up for success. Unfortunately, not everyone will be a reconstructive candidate, because everyone's different. And so, if what we talk about is not right for you, that's okay. And wounds can be managed without surgery. It's probably the majority of the cases, just like Dr. Shem mentioned. But when surgery is the chosen path, I just make sure we're being aggressive. And so I think that's the best way to clear the infection. These infections are, again, very stubborn and very difficult. They cause a lot of problems. Thank you.
Very good. Thank you, Dr. Gupta. Okay, we have a number of questions. First question, how does iron deficiency promote and cause a pressure ulcer?
I think that's probably more for me. So it doesn't promote or cause pressure ulcers. As I mentioned before, pressure ulcers, still pressure. That's what really ultimately causes it. But if you're iron deficient and you're anemic, and as Dr. Gupta was saying, it's really important to have blood flow to wounds and all over our body. So if you're anemic, then there's inadequate blood cells that go to the wounds to help recover. So we try to optimize because as Dr. Gupta said, it's so multifactorial. When we consider patients for flap or just looking at any pressure injuries, even without flap. I have this long list of things I just check off and say, this is taken care of, this is taken care of, and this is taken care of. And anemia, iron deficiency is one of those things that I check off to make sure that you're not iron deficient, and then try to give your body the best chance to recover from the pressure sore.
Okay, very good. Next question. This person wants to know why is it that so many pressure ulcers occur while in hospital as an inpatient person?
Probably because you're still pre-immobile. Out in the community, we're more out and about, maybe moving a little bit more. You learn how to do pressure reliefs. Also, probably has to do with like nutrition changes, hormonal changes, maybe some dehydration. Your skin is just more fragile, and that would be my guess why it tends to happen more frequent. And then we also teach you so that it doesn't happen as much on the outpatient, and that's our hope.
Okay, very good. And by the way, everyone, both doctors are unable to answer your specific questions without obviously assessing you and diagnosing you. So they'll do the best that they can based on your unique circumstances to sort of give you some guidance in terms of what you can do with your primary care physician or your local facility. So just want to be wanted you to be aware of that. Okay, next question. This person has a pretty deep pressure sore under scapula, and their doctor is talking about doing possibly surgery. And the question is, how long after a deep debridement or flap surgery would someone generally have to stay in the surgery? Stay in the surgery. Okay.
Sorry, maybe I'm just so I'm gonna make sure I'm understanding. You mean stay in the hospital after that type of surgery?
Probably, yeah, probably.
Okay.
Yeah.
Yeah.
Hospital or a secondary, probably facility, right?
Okay.
For
sure.
recovery.
A pressure wound around a scapula is one of the more rare ones. I would say it's really hard. And I always want to repeat what Franklin just mentioned, that I can only answer this kind of in very general terms. On a, it really has to be a very specific kind of patient centered evaluation. I would say for me in general, I would anticipate at least 2 or 3 weeks in the hospital, like in an acute care setting. And then I'm depending on kind of different social factors for the patient, it could be 2 or 3 months in like a nursing facility, potentially. I keep in the back of my mind that most of these, I don't get comfortable with how healing looks for somewhere between 6 to 12 weeks. And it's different. Some patients are fast, some patients are slower. It really depends on specific factors. So 12 weeks is about 3 months. So I'm kind of pretty anxious. I really try to do everything I can to optimize healing for the first 3 months. That could mean you're staying in the hospital and I'm checking you every day or twice a day. It could mean you're staying in the hospital 2 weeks and then you can go to a nursing facility. It really depends on kind of what is needed to achieve a healed wound.
Okay, very good. And Dr. Gupta, please go ahead and stop sharing your screen so that we can have the video feed. Great. Okay, so the next question is zinc a topical substance that could be used for stage 1 and stage 2 pressure ulcers?
Oh, the zinc ointment. We don't usually use it, right, Dr. Gupta?
I have not seen it that often.
Yeah, oral zinc sometimes, right? By mouth zinc sometimes, but there's a zinc toxicity concern. So usually short term, most people, I don't prescribe zinc in general.
Yeah, I use zinc for some complicated wounds as a nutritional supplement. It is probably one of the more common culprits to cause upset GI upset, but I haven't used it much topically.
Okay, fair enough. Next question. With more than one sore and having had osteomyelitis in the past, isn't it more likely to occur again?
Probably, yes. Yeah. And then again, I think we have to really look at why did you get it? Dr. Gupta mentioned it quite a bit, but and so if we can avoid the reason why, So somebody who is smoking, and that puts people at risk for breaking down. Can we help you with smoking cessation? If their if the pelvis is unequal and you tend to have more pressure on one side or the other, can we help you with seating? But once you have the wound, yes, it's pretty well known that you tend to have a little bit more than person who almost never ever had wounds.
Okay. Next question. This person is a T7-8 complete with a slow healing stage 4 on sacrum buttocks, currently using wound vac with Prisma. Wound is 4x2x2. They have pretty good leg spasms, and they're wondering if on that basis they might be a good candidate for a flap surgery because of the spasticity in their legs. Is that?
Yeah, no, the spasticity, we can control it. We'll try to control it, especially if you're in the hospital. So after the surgery, your spasticity or spasms can actually get worse because your body's thinking, oh, there's something, what we call noxious stimuli that's happening. But since you are in the hospital, you're not supposed to be getting out of bed anyway. What we do is we really bring up and optimize your antispasm medications. So we do definitely look at it before the surgery and be prepared and can warn you, yes, we're going to medicate you. We really do not want spasms happening to potentially cause problem with the surgical site. And Dr. Gupta can probably a little bit talk more about what happens if there's hip spasms that people flex their hips. But from medical perspective, we'll do our best to add on, increase your spasm medications and try to control that. So that should not be what I call contraindication for a flap surgery. Dr. Gupta, any thought on that?
Yeah, I agree. I would say, yeah, relative contraindication, not an absolute contraindication, which means we have to think about it and plan ahead for it. Our skin, it slides over our joints when we move. And so if you have a spasm, it's going to pull on the skin. If I've put stitches here, they could tear. So spasms do cause problems. They change the position that you take in bed. It changes how the pressure is distributed when you're lying in bed, and it puts tension on the skin. So spasms are something we try to control before the surgery.
Okay, very good. Next question. For bad bacteria such as Mrsa, could they cause an infection that quickly becomes... Okay, hold on a second. Let me reread this again. How does bad bacteria such as Mrsa cause an infection that quickly becomes what appears as a pressure ulcer? Does that make sense to either of you? So basically bad infection that quickly becomes what appears.
Yeah, MRSA is kind of becoming more and more common in healthcare settings, other institutional settings, as well as in the community. It doesn't necessarily require special care compared to other bacteria. Other bacteria also cause osteomyelitis, and MRSA just has to be recognized, so we change the antibiotic. Otherwise, the rest of the care is actually the same.
Okay. Next question. Can you talk about hip disarticulation with total thigh flap? This person has had 2 previous muscle flaps 20 and 30 years ago. And they also have chronic osteomyelitis.
So that is something that I would definitely involve my orthopedic surgery colleagues. Osteomyelitis starts with bacteria. Bacteria come from our skin. As soon as there is a break in the skin, the bacteria can enter. And again, the place where we see the osteomyelitis most frequently is usually like ischial, like the sitting bones or sacrum, but it ends up being a single point where the skin broke first. From that point, either the osteomyelitis will spread or it won't. It will get better with antibiotics and surgery or medicine or whatever you need. And so if it has spread to such an extent through the other bones in the pelvis, that is something that I alone as a plastic surgeon don't treat. And that is something where an orthopedic surgeon might get involved. Again, if the osteomyelitis has spread so significantly or so far that a large portion of the pelvic girdle has become infected, then hip disarticulation or girdle stone becomes more common.
Okay, very good. All right, next question, which really probably applies to a good number of people on this call. This person is in Sacramento, and they're asking how they can get a referral to Dr. Gupta to discuss an issue with their sores and whether or not he recommends starting with talking to a plastic surgeon near them. I think that the challenge has always been that once you leave the metropolitan areas, access to qualified clinicians becomes challenging. So how would you recommend, how would the two of you recommend people who are dealing with serious pressure ulcers and pressure injuries get the proper care and expertise that they need?
Well, if you can come here, in terms of distance, in terms of your insurance, we have had patients, and the farthest I remember we had was somebody came from Reno to do a flap surgery, and it was quite successful, even out of state, right? However, so the way we start out is, as Dr. Gupta said, this is a co-treatment, co-management, and I, as a non-surgical person, I need to prepare the patient to optimize success of flap surgery, assuming flap surgery is appropriate and recommended. So most people start out with actually seeing me first, and I'll go over all the nutritional things, the risk factors, optimizing you again in terms of therapies, equipment, transfers, and all that. Once that's done, and then we kind of prepare you, then we will see you together with Dr. Gupta, and then say what are the surgical options that you may have. But if you come from far, sometimes we'll try to see you together the first time to minimize the number of visits you come here. I also, what I've done is I also talk to your providers locally and go over some of the basics issues, what's been going on. And the other big commitment that we haven't really mentioned too much, although Dr. Gupta said a little bit, is that after the surgery, for flap surgery, typically we need you to be in a nursing home for 3 months. And that needs to happen here. So that Reno patient came all the way here. The nursing home stay 3 months post-surgery was done locally here in San Jose. So unless you can, you have that commitment that you can make, then we don't really recommend you come here for us if you cannot make that commitment.
Okay. And that sort of dovetails into this next comment. This person is asking how they can stay immobile for 3 months if they live alone. So sounds like living alone, recovering from a pressure ulcer surgery especially, is not really practical because, the wound care, the wound sort of dressing changes and all that stuff that needs to be done by someone qualified. And obviously no one can be sitting up at any point during those 3 months.
Correct. So 8 to 12 weeks after a typical flap surgery, we ask you to stay in bed completely flat, not even ranging your hip. And you cannot sit up to eat. You need to turn to the side to eat. So you're unfortunately essentially 100% dependent during that time. So if you cannot commit to staying at a nursing home, then we would usually decline the surgery.
Do those two things usually go together, Dr. Shem, from your experience in terms of insurance coverage, that it's understood after a significant flap surgery that there is this need for 3 months of recovery at a nursing home?
Yes. Yes.
Okay.
Yeah, Medicare will cover that. Most other insurers have covered that.
Okay, very good. Okay, next question. Someone is asking about silver gel or silver material for all 4 stages of pressure ulcers. Probably not quite accurate, right?
Like a silver sword, yeah.
Yeah, so there are a lot of products with silver, and silver is just basically a natural antibiotic. It's effective against bacteria, and it's a natural substance. It's just not a medication. Silver is a very acceptable way to take care of wounds. But there are other considerations as well. Like is it like a water-based gel? Is it absorptive? Is it a sponge? Is there a lot of drainage from the wound? Is it infected? So silver alone is not, it's not perfect for every wound.
Okay. Alrighty, next question. This person has an open pressure sore on their left buttocks, and they have an upcoming plastic surgery. The doctor is not sure which of 2 surgeries he will do, either a muscle flap or just fill in with his own body fat and close it up. All depends on the MRI that they need to get done. Pros and cons of each, Dr. Gupta, a muscle flap or filling in with the body fat.
Okay, I'm not sure exactly what filling in with body fat means exactly, but definitely ask your surgeon. So, but I will tell you in general terms that I think this might refer to what I talked about in my slide, which is either, most of the time we either use a muscle flap or a fascicutaneous flap. A fascicutaneous flap is the skin and fat. We all have fat underneath our skin. And so when you move the skin and fat over the bone, that's a fascicutaneous flap. When you have to use the muscle, that's a muscle flap. The advantages of muscle are, again, that they're very, very good at treating infections, and they're not very good at withstanding pressure. Fascicutaneous flaps are not as good at treating infections, but they're very good at withstanding pressure. So I think it has to be, and it's not black and white, they're both in this gray area. And so I think it has to be kind of an individual case-by-case decision. And I often, especially if I think that the pressure wound has been caused by something very specific, identifiable, a specific airplane ride, a specific car ride, it's not going to happen again. I made a point not to burn too many bridges because sometimes these come back and I need more options in the future, but sometimes I'll do both. I'll do a muscle flap and a fascicutaneous flap because I know that this patient's very low risk of this happening again. So I want to give them the very best reconstruction I can up front.
Okay, very good. Next question. This person is 6 months post-flap surgery and they're fighting to keep the skin intact. It's a struggle for them. Do you have any sort of advice on what people can do when they find themselves in that situation? I guess probably stay off of it, huh?
Well, yeah. I mean, again, you have to look at that entire list of factors. Is it because of poor nutrition? Is it because the patient's taking steroid medications? Is it because of spasms? Is it because of infection? You have to start all over again. By 6 months, if you're struggling to keep the wound closed, that basically means it didn't work, and you're in denial about keeping this together at this point. So it's a challenge because again, it looks small on the outside, but deep inside, there's usually a real problem, and it's hard to admit that. I get it.
Very good. Dr. Shem, you mentioned at the onset about the challenges of people doing pressure relief, and it is real. Are there any sort of topical creams or something to help, just give the skin a little bit of a fighting chance to avoid abrasions that, they start with a stage 1 and then next thing you know, they're in stage 2? Anything that you would suggest? I know you showed a slide that had a number of sort of ointments or creams, but what would be something that could be used on an ongoing basis?
So moisturizer in general will probably be not a bad idea if you have dry wound, but dry skin. But fragile skin, it still just comes down to pressure. But I do have someone who's a few patients that have those fragile skin that's really ready to open, but you're trying really best to keep that closed. Those are leave-in or Meplex foam type cushion dressing coverage might actually, or Deoderm might actually, rather than cream, because cream doesn't give you any pressure reliefs at all, or protection per se. Other than that, it keeps your skin moist and less fragile. Unfortunately, the difficult part is that unless this is a catch-22 kind of thing, where unless you have a wound, most insurance don't cover those nice Meplex or leave-ins and Deoderms and all those skin protection that really would help. But I do have quite a few patients that use those and then minimize or prevent the skin from opening when it's fragile.
Okay, very good. Believe it or not, we have someone all the way from, I believe, Nigeria. So,
oh my.
Yeah, you two must be very popular for them to be hanging around. They're having a major challenge with the pressure sore, and they're asking, for that magical solution. And I think I could speak on behalf of both of you that there is no magical solution. It's really, I encourage you to watch this video recording once you get it. There are so many factors that play into your recovery and your successful recovery that I wish both Dr. Shem and Dr. Gupta can tell you, yep, use this cream, but it's just not there. So I'm sorry that I unless Dr. Shem and Gupta have anything else to say about that, I'll leave it with that.
I agree.
Very good. Well, Dr. Shem, that was one staggering figure you started your presentation with. 80% of individuals with SCI will experience a pressure sore. It is just a very debilitating part of our spinal cord injuries. But thank you so much for both of you for at least sharing. Our aim with these presentations is to educate people so that they will be better aware and educated about the warning signals that usually come up weeks and months ahead, and you have a chance to do something about it. You may not be able to prevent it altogether, but hopefully it's not going to get to stages 3 and 4, and you'll be a client of Dr. Gupta's. Believe me, I don't think Dr. Gupta would much rather not see people like you at his practice. But I thank both of you for taking your time out of your evening to present our audience with this valuable information. Once again, everyone, tonight's presentation has been recorded, and we will be sending you an email tomorrow morning first thing with a link to the video recording of this thing so that you could refresh your recollection with all the valuable information that both doctors were able to present you. Dr. Gupta, Dr. Shem, thank you so much for your time again, for your dedication to serve the spinal cord injury community. Have a good night, everyone.
Thank you, Franklin. Thank you, everyone.
Right.
Bye-bye.
Right.